Thank you. I appreciate this opportunity to really provide a window for you into the work that's been going on for almost a decade now on engaging the non-dental workforce in the fight for oral health nationally. And I'd like to start by mentioning that, as I often do that, in February 2007, when newspapers were directing our attention at the death of Diamante Driver, there were millions of adults suffering from the silent epidemic of oral disease, a disease that's deeply rooted in what we believe to be the systematic barriers in the way that we organize and deliver care. At that time, if you were a physician, a PA, a nurse practitioner, or a social worker, you likely read the story and said, what a shame, we can't do anything about that. Too bad they couldn't find a dentist. These are the same providers that are treating older adults with chronic diseases, of which it's been estimated 90% have oral manifestations. But again, that's always been considered the dentist's domain. Well, for the last 10 years, the NIOH has really helped these providers learn that by redefining the problem and viewing it through the lens of an integrated care delivery system, they're very much an important part of this oral health solution. So how did we get here? Well, you just heard many patients in this country see a physician who don't see a dentist. Patient care has typically been fragmented. And this doesn't include, though, PAs, nurses, and others who provide primary care, including increasing numbers of patients that are older adults with chronic disease. What this slide does document, though, is 108 million missed opportunities for primary care providers to engage patients in preventive oral health care, in education, in screening for oral disease, and referral to dental professionals. But fragmentation of care doesn't just impact the communication of the provider to that patient. It also impacts the flow of information between providers about their patients' oral health care. By 2060, the U.S. Census Bureau estimates that the number of adults aged 65 and older is expected to hit 98 million. We know that many of these represent populations that are living longer, but also suffer from chronic diseases like diabetes and cardiovascular disease. So what this slide shows us is that typically there's little communication between the medical and dental silos. In fact, the flow of information about the diagnosis and treatment of a chronic disease like diabetes is largely dependent on the patient as conduit. That's not only a tremendous burden on the patient at this point, but it's also an unreliable means of communicating critical health information, which is why open access is so important. I'm not going to go over these. These are the many issues that we've already considered, some of which we'll talk about again tomorrow. But the key here is that given these issues, we have to recognize that fragmentation isn't the only problem. Access to care clearly remains a significant barrier, with 62 million Americans living in dental health profession shortage areas and 2/3 of Medicare recipients that don't have dental coverage. And where do they go? Well, they often end up, as you know, in the rabbit hole of our nation's emergency rooms, where the providers are ill-prepared to deal with patient concerns. So as a country, we needed to consider who else could be engaged in oral health prevention, because the issue of a shortage of providers to provide dental care for our population was not going to be solved soon. So in 2009, to address the systemic problem, the NIOH evolved as a consortium of funders, health professionals, national organizations, with the shared goal of eradicating dental disease. Our assumption was that if we could integrate oral health into the education and professional development of providers, they would enter the workforce ready and able to work together to create a new standard of oral health in primary care. The NIOH is a systems change initiative. We provide backbone support and interprofessional agreement and alignment around an interprofessional oral health workforce for whole person care. We work across multiple health professions, including medicine, dentistry, nursing, physician assistants, social work, pharmacy, to really push oral health care across our healthcare system. Now, oral health integration isn't a new concept, and this graphic captures the opportunity for change since the Surgeon General's first report. And we see the progression and the growth of policy documents that have been driving change across our healthcare system. We know that 2 of these documents have given a big lift to our oral health integration movement. HRSA's report on the integration of oral health in primary care describes the what we can do by defining a set of core oral health competencies for non-dental providers. The Interprofessional Education's collaborative Core Competencies for Practice describes the how we'll work together in a team-based interprofessional care environment. However, we recognize that while these and other scientific evidence is important, change happens not only as a result of the research and policy analysis that we've been talking about today, but also as a result of the investments we make in people that can make change happen. Therefore, since 2009, the NIOH has strategically sought to promote change by cultivating leadership, facilitating interprofessional learning and agreement, and developing and supporting tools and resources that create a common knowledge base and vocabulary to bridge understanding, communication, and skills related to oral health. These strategies inspire a philosophy we like to think of as collective impact, where we work across health professions in mutually supportive ways to create a movement that drives change, leveraging the unique capacities of each partner to maximize our impact. So I'd like to shift our attention to 2 of the many tools and resources that are helping prepare the primary care workforce to integrate oral health. Smiles for Life is a free product of the Society of Teachers for Family Medicine. It's the nation's most comprehensive and widely used oral health curriculum, with 8 independent modules that extend across the lifespan. Module 8 covers the unique issues of older adults. The modules can be used as educational coursework as it logs and tracks progress through a back-end database. And it also provides most health professionals with up to 8 hours of free continuing education. Because it's profession neutral, these modules are used now by health centers and programs, nursing homes, to educate all staff in a common oral health curriculum, including specific information on team-based interprofessional care. A new series of modules was recently adapted for frontline health workers with a specific focus on a need for older adult care. These workers, CHWs, promotores, care coordinators, navigators, really extend our linkages from healthcare, the healthcare visit, into the community. It's that other 80%, those social determinants of health, that we don't often consider. The endorsement of 8 health professions and over 20 professional organizations really documents the widespread acceptance of the curriculum across health professions. But perhaps more importantly, I think it recognizes growing interprofessional agreement on the need for shared ownership of oral health care. This year will take us over the 2 million mark in discrete site visits. At the end of 2018, we had over 300,000 courses completed for credit by registered users. So when we say nothing's happened, things are happening. And in fact, we know that these numbers only recognize a small portion of those users because no one has to register to use Smiles for Life. So while the curriculum and the database helps us track the spread of the curriculum, it doesn't tell us how it might be impacting practice or patient outcomes. So in a recent survey, we asked providers whether Smiles for Life influenced their activities by causing them to start an activity, to perform that activity more regularly, or to do that activity better. Referrals are something we expect routinely from primary care providers, yet even with that, we see that a third appeared to do this more regularly, and about 40% felt that they did this better. In terms of anticipatory guidance, 60% felt they did this better, and almost 50% said they began applying fluoride varnish as a result of the curriculum. Almost 60% said they felt they did a better job of caries risk assessment, with about the same number doing a better oral exam. And almost 50% felt that they did a better oral cancer screening. In summary, we found that Smiles for Life appeared to positively influence the practice of providers across professions. But we also learned that organizational factors could influence the uptake of oral health activities, particularly due to the way that we systematically organize care. Which leads me quickly to the second tool that I want to mention. In 2014, with funding from our Cora Foundation, the DentaQuest Foundation, and the Kansas Reach Foundation, we were able to commission Qualis Health to create a framework and toolkit that would make it easier to integrate oral health in primary care. The white paper makes the case for oral health integration and goes on to define an oral health delivery framework that consists of 5 actions that primary care teams can take to protect and promote their patients' oral health. Ask about risk factors and symptoms, look for signs of active risk or oral disease, decide on the most appropriate response, act to offer preventive interventions or referral for treatment, and document through structured data for shared decision-making and population management. In order to test the framework, we help to support and evaluate the work of various integration models that address that oral health prevention gap, those missed opportunities that I mentioned earlier. 19 diverse primary care practices participated in the effort, including both rural and urban settings. The sites each selected a specific population, notably 12 adult patients with diabetes, and we had 5 different electronic health records. In 2016, Qualis Health released an implementation guide, a toolkit that reflected our experience field testing this instrument. The guide is free and includes specific tools and resources that practices found helpful. For example, referral agreements, patient engagement strategies, family educational materials. These tools help settings customize their integration efforts based on their setting, their staffing, and most importantly, their patient population. We know that the policies and rules that govern our healthcare system are often national. However, our solutions need to be local, responsive to the communities and the populations that we're serving. So what have we learned? We've learned that the organizational change process requires system-wide integration, that having the right people in the right place for the right reason can change ideas and practice, that we need the right tools and strategies to impact the knowledge, skills, and attitudes of all of our providers, and that collaboration is key. We can't do this alone. So I'd like to stress that we need to move beyond the symptoms of health disparities to really addressing our policy and funding at changing the structure that creates those disparities to begin with. We need to continue to work together to create a shared vision of whole person care across our medical and dental silos. And we need to define shared performance measures that will allow us to catalyze new evaluation strategies that really can focus on prevention, value, and population health. I want to call out a special thanks to our legacy funders, the Cora and DentaQuest Foundations. Really, for the past 10 years, they've been supporting us in creating a new model and a new standard for interprofessional whole person care. So thank you.